Hello, everyone, and welcome to our second session today of the Family Conference portion of the 35th Annual Family Conference for the National MPS Society. I'm Terry Klein, the President and CEO, and it's my honor to introduce a couple of really incredible physicians and researchers in this space for the session of what we call neurocognitive manifestations in MPS disorders. I do implore you all to ask questions in the chat box that you'll see there on your screen. We will have a live Q&A with both Dr. Elsa Shapiro and Dr. Julie Eisengart at the end of both of their presentations. Let me first introduce Dr. Elsa Shapiro, who will be speaking on the natural history of MPS disorders. What do we know? What do we need to know about cognition over time? Dr. Shapiro is partially retired as a professor in pediatrics and neurology at the University of Minnesota Medical School, and she is the former director of the Pediatric Neuropsychology. She currently is a partner in Shapiro Neuropsychology Consulting, providing consultation in cognitive behavior endpoints for clinical trials. Dr. Shapiro, internationally known for her work in defining childhood dementia and in the development of longitudinal methods to study outcomes in neurodegenerative conditions. In 2020, she was the educational director and lead faculty for an MPS master class. This 2-week course, in partnership with the National MPS Society and the University of Minnesota Neurodevelopmental Program in Rare Diseases, brought critical insights to more than 70 master's and doctoral level psychologists and neuropsychologists who see patients with MPS at major academic medical centers around the world. Her publications encompass neurocognitive, neurobehavioral, and neuroimaging profiles, natural history, and the treatment effects in neurodegenerative disorders. I welcome Dr. Elsa Shapiro.
Hello. I want to thank the NPS Society today for inviting me to this important meeting. I want to welcome you to this session on the cognitive and behavioral aspects of MPS disorders. My presentation today will focus on the natural history of cognitive function in MPS disorders and how that information can help point out the gaps in research. And it will also make clinical trials for these disorders better able to enhance the quality of life and decrease the family burden of these diseases. So I'm going to be talking about 3 different things. I'm going to talk first about typical child development and how do children with MPS diverge from expected development. And then I'm going to talk about each of the MPS disorders and what we know about each MPS disorder from research studies, and then what research is needed to fill the gaps so that treatments can be developed and they can be tested. So neurocognition in children develops in sequence, and it develops in sequence from sensory, motor to learning, social, language, problem solving, attention, and executive function. Those are all in sequence over age. And I'm going to talk about each of these domains and how they are affected in MPS disorders. So sensory motor functions are the first skills to develop: seeing, feeling, tasting, smelling. They develop relatively normally in MPS II, with the exception of hearing. Poor hearing loss can impair the development of language. Other MPSs also have hearing loss, but it's especially the case in MPS II. Motor skills also develop very early. The ability to use your hands, to navigate your environment, to produce the speeches that are necessary for language, to the speech sounds that are necessary for language. And the thing that's important to remember is that poor motor skills in children with MPS disorders can also lead to other problems like impaired spatial ability, and oral motor problems can lead to impaired speech, and joint and muscle problems impair fine motor skills. After sensory motor function develops in the first few months of life, learning, social cognition, that is the ability to interact with others, and language develop in the first year of life. In the neuronopathic MPS disorders, those that have severe brain problems, this process slows and acquisition becomes more difficult, and children lose their already developed skills. Social communication starts with eye contact and physical communication. And most MPS children have good social responsiveness, but in MPS 2 and 3, we see loss of those skills, which is devastating for parent and child interaction. Language begins early also with babbling and simple words. Now, the problem in measuring this in children is that it's affected by their environment, their culture, their education, the parent education, and their parenting skills. But most MPS children acquire some language, and it's a strength for children who have more attenuated or milder disorders. Problem-solving ability is correlated with cognitive function in MPS children. And they begin to learn to problem solve in the first couple of years of life. Attention span comes a little bit later, but they can pay attention to interesting stimuli early on. But many children with MPS disorders struggle with inattention. Inattention can prevent a child from attaining their potential. And then finally, executive function, which is at the very end of development, is planning, organization, self-monitoring, and self-control. This is the function that is the last to develop, but very important in daily living skills. And many children with MPS disorders struggle with developing these skills. So I think many of you have seen this diagram before, and it's mainly to point out that brain disease in MPS disorders is just one part of a larger disease process that can affect the entire individual. These are some of the different somatic problems that children have who have MPS disorders. And sometimes these somatic problems can affect the cognitive and behavioral development of the child in major ways. And also, these problems have a major impact on the quality of life in the child and the family. Not only the brain disease that children have, but also these somatic problems. It often results in disability and requires a lot of caretaker assistance. So in most of the MPS disorders, abnormality in the brain is associated with a spectrum of cognitive and behavioral effects. So you can have progressive neuronopathic disease, like in MPS 1, 2, and 3, where you have a normal development and then slowing and halting and then loss of acquired skills. These are lethal diseases in most part. There's a type of neuronopathic disease, however, is non-progressive. This is particularly true in MPS II, but maybe in some of the other diseases as well. And the brain may be affected, but it doesn't progress to a loss of already acquired skills. It's just that the child develops to a level and then stays at that level. And then there are the non-neuronopathic forms of MPS, where there's no discernible effect on brain structure or function, but sometimes there are hidden effects, and I'm going to talk a little bit about those as well. So to go through each of the MPS disorders, I'm going to quickly go through all of them and describe a little bit about the natural history and then the treatment, what's needed for treatment and clinical trials. So MPS I is a progressive disease, and without brain treatment, children decline after the 3rd year of life, and they die between 5 and 10. However, it's the only MPS disorder with a standard treatment that affects the brain. And transplant, whether it's bone marrow or cord blood, will halt the disease, and children end up, usually depending on the age that they had their treatment, in either normal or just below normal levels. Earlier treatments lead to better outcomes for these patients. Now, ERT does not treat the brain, but it slows the somatic problems, which also can lead to better outcomes. And especially combining ERT and transplant, you can have a better outcome. Now, long-term follow-up for patients with Hurler syndrome is that they have attention and processing problems, which I mentioned before as being something that's later in development, but it's also something that's specifically problematic for these children. So what leads to better cognitive outcomes? Age at transplant, the developmental age that the child has at the time of transplant, what kind of mutation they have, the severity of their somatic disease, and better environmental resources, better school support, family support, and therapies. The presence of hydrocephalus before transplant is a problem, and this remains to be studied. We're now at the point where we can do newborn screening with these children, and that allows identification that's early enough to result in normal cognitive development after transplant. So what kinds of studies are needed for Hurler syndrome, MPS IH? Because most patients are currently treated with transplant, studies documenting the natural history are not needed. What is needed are identifying predictors of good outcomes, novel therapies to address the residual problems these children have, and finding out about how we can better predict what the developmental course will be in children who have been identified with newborn screening. In attenuated MPS I, it used to be called Hurler-Shey and Shey. Those are labels of convenience. This is a spectrum of severity from very mild to almost as severe as Hurler syndrome. Many of these patients have cognitive problems, particularly those who have had hydrocephalus. But the problems are primarily in short-term memory, attention, and processing efficiency. And these kinds of problems, as you well know, may affect the long-term success of these children their quality of life as well. And many of them have trouble with daily living skills due to the skeletal problems, which are not well treated with transplant or ERT in the case of attenuated disease. And again, for these children, educational, social, and rehab therapies are really important for improving quality of life. Now, for MPS 1, there's a real need for longitudinal prospective studies to address attention, executive function, and cognition in the attenuated group, particularly studying the effects of somatic disease and their genotype. And how does the length of time on ERT, for example, affect their long-term outcome? Now, MPS 2 has an onset and slowing of cognitive development after age 2, a little bit later than MPS 1. And diagnosis usually results from the physical symptoms that the child has and not their developmental concerns, which come a little bit later than MPS 1. Many children with MPS 2 have speech and language problems because they have, most of them have hearing loss. And that needs to be attended to as soon as possible to prevent later language difficulties. Cessation of development in Hunter syndrome varies from 3 to 5 years of age, and there's many children have a prolonged plateau without learning new skills, but not losing them either. And during this time, there can be an onset of severe behavioral difficulties. Loss of acquired milestones usually doesn't occur till 4, sometimes much later than that. And some children stop developing and don't decline for years afterwards. Now here's in one of the papers I wrote, this is a picture of 3 studies that looked at the development and plateauing and decline of children over time with MPS 2. You see that most of them never achieved a level much beyond 3 years of age. Now, these 3 studies have little different results, mainly because this one was done a long time ago. This one was done with a lot of severe patients who hadn't, who came late to this clinic in their treatment. And this was done as a research project in Japan. And I'm going to talk about that study in just a minute. So you've got different measures that were used, and getting subjects to participate was a different process. So that's the reason for this variation across different studies. This is a study that was recently done in Japan that demonstrates how the genetic type, the mutation type, can alter the developmental course of the children. You can see this dark line is the children with more severe mutations, and this is the children with the milder mutations, severe nevertheless, but not as severe as these. So you see a little bit of difference in the rate at which they decline. But predicting the cognitive development of these children who have MPS 2 has been very, very difficult. So there's a need for longitudinal prospective studies to be able to predict which kind of path the child is going to have with regard to their cognitive development. And we need to understand how somatic symptoms, their genotypes, and biomarkers may affect their development. And also because these children all have behavioral problems, or many of them do, what is the interaction of this behavior with neurocognitive development? Now, attenuated MPS II is a spectrum of severity. Some of them have, this is what is called non-neuronopathic. I don't like that term because it implies that there's no brain problems, which I don't think is really true. Many of these children have short-term memory, attention, and processing problems, particularly during adolescence. And these problems, as I've said before, can affect long-term success, adaptive skills, and quality of life. And again, ERT does not treat brain problems. Only educational, social, and rehab therapies can be useful for treatment for these patients. Hydrocephalus is a factor, and it needs to be monitored. And there's a real need to study the attention and executive functions of patients with attenuated or non-neuronopathic MPS II to understand what the brain basis of their cognitive problems are, and what the somatic symptoms, their genotype, and how long they've been on ERT may affect their cognitive abilities. To move on to MPS III, there are 4 types, A, B, C, and D. We know much more about A and B. They're more common. They have few somatic symptoms, some, but they're not predominant. Mainly, they have cognitive decline. And they're the primary symptoms, along with severe behavior and sleep problems, which correlate with the cognitive decline. Normal first-year development, slowing, plateauing, and then declining after about 48 months. This is the best characterized natural history. We don't need more natural history studies for MPS IIIA and B. We do, however, there's a dire need to characterize the natural history of 3C and D, which may have an onset later and have a slower progression, but we don't even know that at this point. So here's an analysis of 3 natural history studies that I did. I combined all the data from 3 studies, and it really reveals how pretty compact this disease is in terms of the decline. Most children by 54 months have begun to decline in their cognitive ability. This is for kids who have rapid progressing disease. And then by 24 months, they've actually started to decline. So anyway, this is what happens. They develop, they stay the same, and then they decline. This is on 62 patients and 197 visits. So that's a pretty good number of patients. And most of the clinical trials that have been done so far have started too late, and the duration of the studies have been too short in order to demonstrate whether or not there's been any sort of benefit of any kind of new treatment for this devastating disease. So there's a need to combine the natural history data for MPS III to provide robust comparator data. So we don't have to have any more natural history studies. We do need to understand the slower progressing and attenuated patients better. We don't know very much about them. And that's an area that needs research. And certainly in C and D, international longitudinal or cross-sectional, prospective or retrospective, any kind of study that will illuminate what the developmental trajectory of C and D are will be of great use. So I'm moving on to MPS 4, Morcheo syndrome, which has two forms which are clinically indistinguishable. Most of the research is on 4A. 4B is ultra rare. It has a spectrum of severity with an early onset form, which has a lot of somatic problems and very severe, and the mild disease, which may have a close to normal lifespan. MPS 4 does not have progressive cognitive impairment, but it's been assumed that it's without cognitive impairment. And I'll show you some data that suggests that might be not true. It's a visceral and skeletal disorder with short stature and impaired endurance, respiratory problems, cervical spine instability, and actually impaired quality of life, because many of these patients have a lot of pain and they have hearing loss, and the effects on cognition are not well known. So there are 4 studies that have been carried out in MPS 4. That's it for natural history of cognitive ability. A cross-sectional study found 5 patients below average, but mainly they were unable to sit still and concentrate and talking too much. That's sort of an odd observation, but authors drew parallels to Williams syndrome, which has that symptom as well. That needs to be better investigated. We don't know that that's really true. And 2 other studies indicated problems with visual search and maintaining gaze and poor sustained attention. And so I think that these studies suggest that MPS 4 may have difficulties with executive functions, such as attention and visual processing. There are really no cognitive natural history studies. We need to understand how mobility problems, hearing loss, and pain alter their life experience, quality of life, and even cognition. Although depression and anxiety are mentioned in the literature, nobody's ever investigated that. And so to improve quality of life and optimal outcomes, it's important to do natural history studies in these patients. And so what we need are cross-sectional and longitudinal studies of neurocognition, including IQ and attention and executive function. We also need to consider the effects of somatic symptoms, mobility, hearing loss, and pain on neurocognition, behavior, and quality of life. 4B really doesn't, there have been no studies, and there need to be some retrospective studies. Due to rarity, I think prospective studies may be very difficult to accomplish with these patients. MPS 6 appears to have both a rapid and slow phenotype. The rapid phenotype may have symptoms before age 2. Without treatment, life expectancy is less than 20 years, but ERT treats the somatic symptoms, but not any symptoms that result from brain involvement. So there's short stature, facial coarsening, skeletal abnormalities, cardiac involvement, corneal clouding, lots of physical symptoms, without progressive cognitive impairment. However, it is the case that several studies have indicated that, and there are 2 important studies, that a number of these studies, 5 out of 25 patients, had an IQ in the cognitively impaired range. And one of the things that was important was that the severity of physical symptoms was associated with a lower IQ and attention score. Another natural history study on 11 children found 4 had progressing disease, but a lot of them were stable over time. We just don't know enough. We know that ERT is effective. We know that treatment transplant has been done, but it's not being done because of the risks involved now. But we know that it benefits symptoms both peripheral and central. There's an important need for cognitive natural history studies. Longitudinal prospective studies to improve our understanding of neurocognitive development, as well as attention, executive function, processing speed, and memory. These are all very important for MPS 6 to understand the effects of these cognitive problems on quality of life. We also need considerations of the contribution of somatic severity, mobility, their genotypes, and biomarkers to their cognitive outcomes. Finally, MPS 7 has a global incidence of less than 200 patients. Up to now, no natural history studies of cognitive functions have been carried out. The disease varies from mild to severe, similar to MPS 1 and 2, with short stature, skeletal problems, liver, cardiac, and lung problems. The cognitive impairment seems to be similar to Hurler syndrome, but we have no idea about the timing of progression. This is unique because of an infantile form, which doesn't seem to affect cognitive outcome if the children survive this form of MPS 7. Transplant has had variable success. There's now a peripheral ERT, which was just approved a few years ago, and a long-term disease monitoring program is being carried out now with cognitive data. Although ERT isn't expected to affect the approved ERT will not affect cognition, outcomes may be improved by better somatic status in motor, hearing, and physical well-being. And data from this disease monitoring program will provide great comparative data for later brain treatments in these patients. So we need an international longitudinal prospective or retrospective study to describe the cognitive and behavioral problems, as well as the effect of the infantile form on cognitive outcomes. And I think that the disease monitoring program that is currently ongoing will contribute some initial data to that effort. So that's my survey of all of the MPS disorders. I'm going to close by saying a few words. Functional outcomes of brain treatment are hard to measure. Correlation of biomarkers and MRI, for example, with clinical function have not been determined for any of these diseases. And the timelines of clinical trials are not well defined. What age do you start? How long do you monitor? These are all areas that are unknown at this point and need to be further defined by natural history studies. And there's a dire need for collaboration between advocacy, academia, regulators, and pharma companies in order to get this important work done. Thank you for your attention. And now I turn it over to Dr. Julie Eisengart.
Hello. Before Dr. Eisengart presents, I just wanted to thank Dr. Shapiro for this incredible amount of information that's provided to us on this natural history study of the MPS disorders. It's we've requested it. Many people have asked about how do we have a look at this, and I know this was a lot of work for you to put together. So to present this information here, I'm sure will become the most highly valuable asset, not only to future research, but to clinicians worldwide. So thank you. A reminder again to please post questions into the chat box. I am starting to get them in, and we will field all questions after Dr. Julie Eisengart's presentation. So let me first introduce her properly. She will be presenting on the neurobehavioral manifestations and impacts of MPS. Dr. Julie Eisengart is an assistant professor of pediatrics and neuropsychology at the University of Minnesota and the director of the university's neurodevelopmental program in rare disease. Her research focuses on rare neurodegenerative disorders of childhood, particularly the relationships between the brain structure, biomarker abnormalities, and brain function, with the goal of predicting outcomes and improving supportive planning. She has served also as principal and co-investigator on a number of observational studies or clinical trials for MPS and other rare diseases. Dr. Eisengart has served as an advisor for the Minnesota Department of Health on implementation of newborn screening for MPS I and other disorders, a consultant on the CPATH Institute Rare Diseases Subcommittee, and she is also a member of our scientific advisory board here at the National MPS Society. Her findings on rare diseases have been published in journals including Genetics and Medicine, JAMA Neurology, Blood, Neurology, Molecular Genetics, and Metabolism, and Orphanet Journal of Rare Diseases. I welcome Dr. Julie Eisengart.
Thank you, Elsa. Hi, I'm Julie Eisengart, and I want to thank the Society for the invitation to speak at this important meeting. I'm going to be talking about the neurobehavioral manifestations and impacts in MPS. So before I begin, here are my conflicts. Today, I'm going to be talking about the neurobehavioral symptoms in MPS and their impact on the individual and the family. Talk a little bit about some management techniques, and then touch upon future directions because there's quite a bit of work to do in this area. So the neurobehavioral symptoms and their causes are far more complex than just evidence of MPS disease in the brain. As complicated and multi-system, head to toe as the set of MPS disorders is, it's just that complicated in terms of the many factors that could be contributing to behaviors, whether it be pain, sensory deficits, challenges with communication, seizures or the seizure medications, various other things. I won't read the whole list to you, but these are just some examples. And when we think about the neurobehavioral symptoms, we can kind of roughly categorize them into two parts. There are the really obvious observable ones that someone can see from across the street or across the room, whether it's really hyperactive behavior, lack of fear, being very physical, impulsive. And then there are the less obvious ones like anxiety, inattention. When inattention is not coupled with hyperactivity or impulsivity, if it's somebody who's just struggling with attentional skills, that can be rather subtle and difficult to detect. So as you see, I don't have every single type of neurobehavioral symptom listed on here, but here are some more examples. Certainly elopement is a very challenging one, particularly in Hunter syndrome and Sanfilippo syndrome, although it can be seen in other types as well, where there's sort of running, and sometimes it seems that the running experience may be the end goal rather than having necessarily a destination. It can cause great concern about safety and other kinds of implications. So when we think about the neurobehavioral profiles of the MPS types, the number one thing to emphasize is this gold box here in the bottom, is that people with MPS are diverse. Any MPS type may show variation in terms of what symptoms are visible or what symptoms are invisible or subtle, shall we say. It really depends on the individual. But what are the MPS types that most often have the visible symptoms, and what are the MPS types that most often have invisible symptoms? So in terms of the visible symptoms, the hyperactivity and some of the behaviors that appear aggressive or have some emotional outbursts, that tends to be the neuronopathic Hunter syndrome, Sanfilippo syndrome, SLY syndrome. What about the types that tend to have some of the more subtle or invisible symptoms? MPS 1, all the phenotypes, Hurler, the attenuated, kind of formerly known as Hurler, Shea, and Shea, non-neuronopathic Hunter syndrome. But what we think is that it's really likely that all types, to some degree, have some symptoms. MPS 4, MPS 6. Why would this be? Well, if you think back to my other slide where I was describing the many factors that can contribute to neurobehavioral symptoms, across MPS types, there are head-to-toe manifestations of disease that can very easily contribute to some behavioral presentations, and this can really be underappreciated, particularly if there are types that are not necessarily expected to have major behavioral signs. So just to recap and re-emphasize, this sort of categorization of MPS types into subtle versus more striking symptoms does not mean that just because somebody has non-neuronopathic Hunter syndrome that they won't have visible symptoms. We're sort of grouping these into tendencies seen in the types. Now, one of the big sources of strain is the challenge in explaining why there is a behavior. And this causes great stress, particularly for families, caregivers, whether it's parents or siblings, when there are behavioral changes, behavioral exacerbations, because one of the questions is this a sign of pain? Is this person suffering? Along those lines, many times families are forced into the position of being behavioral translators. So in our study of neuronopathic Hunter syndrome, we were looking at, what are some of the challenging behaviors and why. There were really critical interviews with caregivers and, some important advocacy meetings, ad boards, and certainly observations of the affected children that helped us understand that behaviors can be, in one individual, it can be the same behavior, but it might have a different purpose at a different time, or it might have a different driver at a different time. So for example, this illustration from our paper shows that the behavior in and of itself, purposeful collision, that's something that could be, probably has contributed to the literature's large description of children with Hunter syndrome as being aggressive, because running into someone is definitely aggressive appearing, but sometimes that collision might be an attempt at social interaction or an attempt at communication that is, not as effective as, words, but if the person doesn't have words, then, what else are the options? Sometimes that collision can be that seeking of the deep sensory collision pressure. Sometimes it is aggressive. Sometimes it's reflective of a really strong behavioral response, maybe stronger to whatever the provocation was. But often the caregiver is in the position of trying to explain it and hoping that the recipient understands and believes what's being explained. So that contributes to this impact of these behaviors on the family. And about 1.5 years ago, a group of international experts met to update the consensus guidelines that were initially developed in 2016 on ways to design clinical trials and design endpoints for measuring responsiveness to therapy in the neuronopathic MPS disorders. And particularly, what are the important things to measure? In the most recent update, you see this quote here, there's the acknowledgement that the caregiver and family burden is quite high in MPS disorders, not just in neuronopathic, but across the MPS disorders, and that it's really critical to quantify family impact, family burden, family experience over time to reflect whether the therapy in question is affecting not just, CNS disease, brain disease, but also whether there is sort of, I think they call it overspill relief, overspill benefit into the whole family. So what are some of the impacts more specifically of, first we'll talk about the observable symptoms. The affected person has challenges from these neurobehavioral manifestations. First of all, there is the major disruption in sleep as part of the profile of neurobehavioral manifestations. So the fatigue resulting from that disrupted sleep creates a harder day, harder time learning, harder time communicating, and harder time regulating, and the dysregulation also feels quite uncomfortable. There's certainly the social isolation because these behaviors can be very striking and create some distancing from peers who are, potentially intimidated or put off, or just sort of automatically retreat from very expressive behaviors and ones that may be dangerous or aggressive appearing. There's reduced access to educational and community settings because of the behaviors. If the children are inappropriately written off as too difficult to manage, they may be excluded from certain educational environments and certain community environments due to safety concerns. And then, the symptoms themselves reflect a degree of, in many cases, an unrest and a dysregulation that needs some support to achieve a greater level of calm and regulation, even if, in that child's sort of scale of calm is different from an unaffected child's scale of calm, still deserving to have those experiences of calm within that child's span or repertoire. And if the symptoms do not respond to classic methods of behavioral control, then they do not get to enjoy that either. So these are some of the impacts. And then certainly the impacts on the family. First of all, MPS is a traumatic condition for all loving members of the family. There is massive sleep deprivation and fatigue, which completely affects coping and management and, fear of whether I've got it all under control and am caring for my family member in the best way. There's certainly the fear that the symptoms might be reducing as a sign of disease progression. And families have described that it's incredibly difficult to maintain social supports, which are so critical for coping and survival. The family is often quite isolated, making strategic decisions constantly to not participate in events if they've been invited, to engage in community activities at off hours to protect the child and to protect others if the child does have dysregulated behavior, like going to the park at 5 a.m. The behaviors are so challenging for caregivers and educators and clinicians that there haven't been easy answers. There haven't been satisfactory management techniques. And so the caregivers are just forced to figure out how to manage, and often the options are wholly inadequate. access to support programming, whether it's, home health nurses or respite care or developmental centers, that access can be reduced by nature of not qualifying diagnoses, by nature of age range, and by nature of level of physical behaviors or aggression. Often, though, the caregivers explain that they are more concerned about the emotional and behavioral symptoms of the neuronopathic MPS disorders than the cognitive or IQ function. There are also some pretty serious impacts of invisible symptoms. Invisible, or shall I say subtle. There's the impact on the affected person. So this error of attribution that we've really spent some time investigating in terms of some of the really striking, challenging behaviors I described before, those are still occurring for people who might have the less visible symptoms. So for somebody who has low attention or slow processing or anxiety, that can really, really be a barrier toward efficient and easy work engagement and performance. And by work, I mean either educational work or vocational work. And it creates a situation where someone might appear unmotivated or lazy. And, if it's really hard to do something, how can you maintain motivation all the time? I think that's a very normal and fair human response. And then on top of that, feeling defeated and not necessarily constantly having this endless flow of energy and motivation to do something, it's also really, really objectively challenging to engage and do it. And some of that challenged engagement can be mistaken for lack of motivation. This appearance of sort of cherry picking, he only does the things he wants to do. And if he doesn't want to do it, he won't do it. Or if he doesn't like it, he won't do it. That's actually a sign of really fragile attentional skills. So all human beings pay attention better when something is captivating and interesting, and they don't pay attention as well. All of us have been in a situation, hopefully not this lecture, but where you've been sitting and listening and you get a little bored and you kind of have to straighten up and listen up. And that's true for people who have attentional difficulties too, where you sort of naturally disengage when something's not interesting and you engage when it's exciting. And when people have fragile attention, that's just a more dramatic separation, a more dramatic relationship. So these people will appear to be only doing the things they like, when actually it's just that they have success attending when they're doing the things they like. Other issues with some of the invisible disability is a social isolation. There's a real challenge with social emotional processing, particularly as peer groups get into sort of really rapid flowing peer interactions and a lot of subtle jokes here and there and going quickly. For people who are, slow processors, which is seen across MPS types, even if individuals are impulsive. For people who are struggling to pay attention, they may not catch every part of the conversation, may not be able to attend to all the subtle facial expressions of peers. It can make it very difficult to remain socially engaged and socially on top of it. And then that social distancing is compounded by, physical limitations. If there are aspects that someone is feeling, down on themselves about, or other people are making unfair judgments due to short stature, physical limitations, it can just sort of compound the peer relationship development and peer relationship stamina. Also, there are feelings of mental fogginess, sort of being in a fog and not being totally with it, even though intellectually I can comprehend this. I just feel like I'm in a fog. And then all of these things that I'm describing create challenges in the educational and vocational realms in terms of work completion, work accuracy, and kind of their superiors' assessment of how they're doing and how hard they're trying. There is also impact on the affected family. It is traumatic to have a family member who has MPS and be concerned about this person's wellness and the progression and how it might be expressed and whether certain complications are going to arise. Caregivers, family members have challenges with their own employment. There are economic implications which have been so exquisitely sort of laid out in the Every Life Foundation's Economic Burden of Rare Disease investigation. And then there are certainly the self-identity implications for, you know, helping and parenting and supporting and caregiving an individual who has MPS, and particularly constantly having to be in the role of advocate. It's very challenging to support the needs that arise from the invisible limitations. It's challenging to support from the needs that arise from the obvious limitations as well. But also being in the position of hoping that someone will take your word for it, and that you're not just asking for favors and creating kind of a whole experience, constantly needing extra support, extra favors unfairly, but that this is a real thing that, you know, if just given this extra support, you know, my child, my sibling, my individual will show better skills. It's a very, very stressful situation to be in, still being forced to figure out how's best to manage. We don't know. We don't have a perfect answer as to how best to help manage symptoms. What works for inattention? How do we help socially? Some of these situations and circumstances can be really overwhelming and really unfair. So what are some management things? Now, if there were a perfect formula to say this is, you know, you do X, Y, and Z and it will work every time, I would be cheering and screaming it from the mountaintops. But right now what we have is an assembly of ideas that have worked for some, have not worked for others, and in general remain inadequate. But, you know, in continuing with the theme that everybody knows, MPS is not a cookie cutter set of disorders. And so along those lines, the diversity of needs and the diversity of challenges makes the management techniques inevitably, some of the techniques good for some poor for others, and so on. In terms of challenging behaviors, the somatic symptom management, you know, I had touched upon the concerns about whether there's a pain source. For some, ABA, which is you know, an evidence-based therapy that supports individuals with autism and related conditions, can be helpful. There are medications that can be helpful for some, not for others. Rehabilitative and supportive interventions like speech, OT, and PT. Speech can help with communication, and certainly OT and PT can help with things like flexibility, with pain, and further with, you know, some self-regulation, some communication, some pointing, potentially strategies that can help. You know, stimulation, engagement, structure, the things that will help touch and regulate one child may not help and touch and regulate another, but certainly that engagement can help with some of the challenging behavior management, not to mention that it supports the quality of life. And then just being mindful of the potential that there are trauma triggers, right? So we know very well established in, for example, the pediatric cancer literature that a lot of the medical appointments have been associated with medical trauma. I know that there are plenty of wonderful individuals in the MPS community who are doing work in this area. I've had some very intriguing conversations with Melissa Hogan about this, and we are focusing on that in our center as well. For example, you know, just in the past month, we were working with a child who was nonverbal and was very distressed during our appointment, and we did discuss the possibility that there was, you know, a medical trauma trigger, and that the environment itself might have been anxiety provoking. So, you know, we took off our paper masks and replaced them with our homemade cloth ones so that they would look a little less doctorish. There was an increase in regulation and calming. Was it because of that? No one knows, but this child certainly appeared to be more comfortable. Attention types of supports, physical activity to any degree that has been, clearly safe and is comfortable for the individual, whether it's a stretch from the chair, what if someone is walking, if, there's a walk, physical engagement, even if it's just sort of deep breathing, can really refuel attention. Repetition helps with attention, regardless of whether the person understood it. If they've got it, the repetition still helps. Things like preferential seating, medication can really help attention if it has been deemed safe, for example, by your cardiologist specialist or other MPS managing physician as compatible with your or your child's medical profile. In schools, school planning needs to be informed by specialists who get MPS and who can provide some education, and recommendations have to be developed based on the diverse potential areas of need and keeping in mind the invisible disabilities. COVID has been a really challenging time. We've been working really hard to come up with ideas, and that actually gets to my next point, the work underway. So I'm pleased to report that we've assembled a paper. This is in collaboration with Cure Sanfilippo Foundation and Project Alive, and certainly the National MPS Society. With the University of Minnesota Neurodevelopmental Program in Rare Disease, we've put together a paper on supporting neuronopathic MPS in the school. We have a very strong focus in the paper on COVID types of supports, but also for sort of more broadly helping children in the school who have neuronopathic MPS, and particularly if confronted with distance sorts of regulations for whatever reason. That paper has gotten the funding to be freely open access, and it's in the final stages of revision with the journal so that you will have a scientific paper to print out and hopefully bring with you to schools. Please keep your eyes out for announcements when that paper is published. We're hoping that it comes out this summer so that you can use that tool. Other work we're doing is investigation into the challenging behaviors in neuronopathic MPS. The impact on the caregivers, trying to put some data to it to continue to build upon the understanding, and then some very careful investigation into strategies that families are using that have been successful to manage behaviors, or what strategies have not, to really add some more clarity to that. That is being led by Nathan Grant, who many of you may know. It has published on his lived experience with caregiving for his twin brother with neuronopathic Hunter syndrome. We're also launching a study of the neurobehavioral and cognitive complications of non-neuronopathic MPS. So earlier in this talk, when I mentioned that it is likely that there are neurobehavioral manifestations across MPS types, even types that do not have cognitive regression, we're looking at that very closely, and certainly the impact of pain on mental processing. And that is being led by Dr. Brianna Yund, who has long been working in MPS and is one of our postdoctoral fellows. And then we're also launching an MPS Scholars Pilot Program that was generously funded by the National MPS Society. It is a short-term part-time training program for emerging psychologists, because we certainly need more neuropsychologists and psychologists who are specially trained in MPS. So in summary, we really feel it's likely that all MPS types have neurobehavioral symptoms. Some are more clearly apparent than others. The symptoms affect the individual and the family, and we really need these symptoms to be investigated more comprehensively. The drivers and causes, the effects on the individual and family, and certainly management techniques that can be successful. The management requires creativity, and it really requires a whole child, whole disease, whole family approach. thank you so much for your time, and I really look forward to the discussion. I just want to acknowledge the huge team of people who have been so helpful in all of these investigations. I really value the collaboration. Thank you.
Hello, Dr. Eisengart, and as we wait for Dr. Shapiro to bring forth her video for all of us to see, we know that she is here. So we'll go into what we have for some question and answers, because we do have quite a few people who are bringing forward some questions for us. And so why don't we go ahead and we will start first with Dr. Shapiro, if we can. I think this question is really for you. And this question comes from a parent that says, my seven-year-old loved one with MPS II is going through testing for autism. Is this common given the social implications of this diagnosis?
It is common, perhaps a little bit less than MPS III, but it is common that some symptoms of MPS II are similar to those of autism. And I think that it's a valuable tool to get some of the supports and how shall I say it, the treatments that might be available for children with autism. I think it's important for the school to know, or whoever is testing him, that this is not the root cause. He is not autistic in the same way that a child who has, sort of the core symptoms of autism. But the treatments are appropriate, and usually the interventions are appropriate. And I don't think that it necessarily, has any negative social implications. Dr. Eisengart, do you want to chime in on that as well?
Sure, I completely agree that the supports for diagnoses or, kind of struggles that are not necessarily, textbook autism, but might share features, they're really good. And it's really the law that it's not just autism that ABA has to be reimbursed for. It's autism and related disorders. And so in this case, this would be a related disorder. And absolutely, there have been plenty of kind of anecdotal reports that it's been beneficial for families.
Thank you for that. I know that that's been an important question I've heard repeatedly from parents over the years. The next question, again, I'll address it first to Dr. Shapiro, is from a parent. There is a lot of question of ABA use for the behavioral issues. Is there anything to demonstrate the benefit of ABA for MPS?
I don't think there have been any studies that I know of, but I will tell you from anecdotal information that it is quite beneficial in some cases. And I think that it's important to know that while you might not be able to treat the disease, you can treat some of the behavioral and disruptive symptoms with ABA effectively. At least that's my impression from individual cases. I've seen more of that with Sanfilippo than with MPS II. Dr. Eisengart?
Yeah, I've certainly heard that, and I think there's kind of the additional benefit with ABA, the potential for communication helps with some of the frustration, which can then have that, sort of chain reaction benefit, if you will, to reduce some of the behaviors too. So just some improved communication and
just sort of agency and getting things that the person needs and wants.
You're muted, Terry.
Going back to one of the questions from your slides, Dr. Shapiro, you were talking about a definition around non-neuronopathic, not necessarily liking that definition. This comes from a parent of an adult. And they're asking about, are there any studies that might be pending on short-term memory loss, specifically across MPS or ML diseases, as some of these parents have started to have discussions with one another about recognizing these symptoms in those later decades?
Yes, well, I think that's a really big need for the adult patients. I think that Dr. Eisengart mentioned these invisible symptoms, and that is exactly what they are. They are symptoms that are associated with maybe MPS 4, MPS 6, MPS 7, or attenuated diseases, or ML. All of those have associated short-term memory problems. I want to point out that short-term memory is really like attention. It's being able to focus on what somebody is saying and process that information effectively. It doesn't really mean anything about long-term memories. It's just being able to process information. Julie, Dr. Eisengart, you want to mention?
Yeah, I mean, so let's see. So the study that I described that Dr. Yund is kind of prepared to launch really gets at that. And she has worked really hard to design a study that can be administered in a distance fashion so that it is able to be much more inclusive. So there was a really good instrument that Dr. Shapiro first included in the NIH MPS study starting in 2009. And at that time, this instrument was a local instrument. And so anyone who was able to travel to University of Minnesota took it. And Dr. Yund looked at 10 years worth of data on that. And this instrument was able to get at some of the things that, adults and individuals who are not adults but have, some sort of attenuated or non-progressive form of MPS, intellectually non-progressive form of MPS, were able to tell us, really feeling foggy, really feeling like I just, it's sort of this in one ear, out the other is sort of how people were describing it. And this test was actually able to quantify that. So it's a really good test. And so Dr. Yund found that this test actually can now be done on an iPad anywhere. And so that is the study she's designing and is going to be, it's, if you want to hear more about it or learn about it, kind of keep your eyes out, because it's not totally prepared yet, but that will hopefully give some more data to the people who are describing these experiences.
Will that just be MPS 4, or will it be?
That is across any type of MPS.
Okay.
That has non-progressive intellectual, either, sort of IQ within, a kind of a range that would allow them to take an iPad test and that does not involve deterioration.
Thank you, Dr. Eisengart. I just want you to know we had a few people that noted that in your presentation, that they're really pleased to hear that that's going to take place. And so I wanted to share that with you.
Oh, good.
Yeah. The next question for either of you, is there a correlation for any syndrome type between a specific mutation and a certain set of neurological or behavioral symptoms?
I'll answer that first. And there's a bigger correlation with severity, according to specific mutations, than there is with a different syndrome pattern of neurologic or behavioral symptoms. As far as I know, nobody has identified a particular set of symptoms that are associated with a specific mutation, but the severity of symptoms is. And so what we know is that in each disease, there's a pattern of neurologic and behavioral symptoms, and that it depends on the amount of enzyme that is residual enzyme, probably. We don't know that for sure. And the severity of the symptoms. Julie, you've done a little bit of work on that, right?
Right. I mean, I think that really captures it. I mean, there's, no matter what, the variant is not going to be the perfect predictor of how any person is going to present, right? There are so many factors, and there are various, somatic symptoms that can influence, and so, and just life experiences. So, it's really hard to look at a mutation and say, this is what you will see.
Thank you.
You may be able to get a rate of decline from that, but eventually, that's about it, right?
Mm-hmm.
Thank you for that. I'm going to ask just one more question, and I wanted everyone to know that is listening that we have a couple more questions that I will pose back to Dr. Shapiro and Eisengart offline, and we will follow up with the attendees for these last couple of questions we couldn't get to. But here's the last question for now. Are there any notable patterns, and for Dr. Shapiro or Eisengart, are there any notable patterns or triggers that seem to cause regression? For instance, we seem to notice that my child has a hard time coming back after surgeries, and they may have a changed baseline now.
I think that people have noted that surgeries and inflammations and infections may be a precursor to decline. However, it's going to be very difficult to separate that out from just the effects of time, because what happens is that during the recovery period, the child may be declining anyway. And so separating that out is very difficult. Dr. Eisengart.
I agree. And I also think, it's difficult to know what the surgeries were for, how much there's, for example, recovery pain that could also be impacting the picture, because we really know that pain or discomfort or some other kind of physical symptom or physical change, particularly for the children who really, are showing that regression, the degree to which they are reliably able to show a skill set can be really vulnerable to, physical changes. And so it's hard to know.
Well, thank you both, Dr. Shapiro and Dr. Eisengart. It's always so informative, and there's so much knowledge gained for our families when you're presenting to us on a platform like this. We're honored to have you with us today. We're grateful for all that you do for the patient community. And I want to share with everyone else that session 3 for orthopedics and care management is now beginning. And we wish you all the very best. And for the fathers out there, happy Father's Day. Thank you both.
Thank you.
Thank you. Thanks so much.